Welcome to AETCM, the Emergency Medicine Channel. 36-year-old male came to our ER with a alleged history of ingestion of rat poison. On initial 10-second assessment, patient was conscious and oriented and was able to complete full sentence. On primary survey, airway was patent, there is no pooling of secretions, no gurgling or hoarseness of voice. On breathing part, respiratory rate is 16 per minute, saturation is 99% room air, and iron-3 bilateral was equal. Circulation part, BP was 110/70, heart rate is 96 per minute, and all peripheral pulse are felt equal. Disability part, GCS is E4, V5, M6, pupils are bilateral equally reactive.
So this is a case of ratol ingestion. So if there is any co-ingestions or anything, we are not very sure of such things. Okay. So when in a poisoning case, when all will you expect bradycardia? What all co-ingestions or what all toxins will cause bradycardia?
Organophosphorus co-ingestion and organophosphorus.
It can cause both tachycardia and bradycardia based on the response, whether what receptor it is acting. Then beta blockers. Then other than beta blockers, calcium channel blockers. Then digoxin and any rate controlling agents can cause bradycardia. Tachycardia,
atropine, derivatives, alcohol intoxication.
Okay. Okay, fine. Bradypnea, reduced respiratory rate. When all will you expect?
OP poisoning.
OP poisoning. Oh, more than OP?
Morphine.
Opioids. Okay. Then sensorium wise, GCS might be low based on what patient might be taking, or any alcohol overdose or any benzodiazepines. We can expect a low GCS based on what at the it varies based on the patient's time of arrival and rest of the things. And pupils.
Pupils, pinpoint pupils in OP poisoning, opioids, morphine, dilated in atropine derivative poisoning, and alcohol.
Okay.
You told the patient had presented with alleged history of zinc phosphate, right? So at this point, it is very important that you tell what is the duration. I mean, when was it taken, right? Because if the patient is coming with an acute presentation, our initial management and thought process is going to change. So how long before the presentation has the patient received the
patient taken on 23rd December. He just went into outside hospital, one medical college. Then patient reaching here in our hospital as on 28th December.
So it's already like 3-4 days over, right? So another important thing is don't comment on the compound per se, right? You told it is zinc phosphate, right? So what exactly was the commercial preparation? Any idea?
Ratol is the commercial brand taken.
Okay, always these kind of things, even if you get a reference letter saying that this is a chemical, always take the effort to go back, find the history of what exactly the commercial preparation is. Because in India, these sectors not very much regulated. So you might have the same name with a compound, chemical compound, which could be different. You can have the same brand name with 1 or 2 different chemicals. So in this situation, always take extra effort to go back to the history, find the compound, if possible, physically verify the compound, and make sure that the content is same as what is written in the reference letters. From a historical perspective, make sure that this effort is done. Okay, so let us, for all practical purpose, assume that this is definitely ratol, which was confirmed to be zinc phosphate. And we have a patient who has come to us almost like 4 days later, 4 days after the initial ingestion. So yeah, now we can proceed and we'll come back to the history part again.
Exposure temperature is normal. GRBS is 196. As per adjuvants, since 5 days after patient came here, we took a VBG and a serial PT-INR for monitor the progression of the liver status.
So what all are you checking in VBG?
VBG, there is lactate elevation, metabolic acidosis, anything is there. Creatinine.
So when will lactate elevation come?
Patient come into liver failure. Lactate is mainly delivered by liver. So if lactate is elevated, we know that means liver is into failure. And for creatine, in our VBG, creatine is available. So some person goes acute kidney injury also. Then bicarbonate and acid-base disorder. Then also we look in bilirubin is elevating.
Okay.
Then calcium, ionized calcium also, some portion of hypercalcemia also.
So basically, to understand what all investigations you have to look for, you should understand the phases of progression, right, in zinc phosphate. So classically in zinc phosphate, there are 3 phases, right? You have the phase 1, phase 2, and the phase 3. Phase 1 is acute toxicity, where you have all those cardiac and hypotension, arrhythmias, and things like that. Then you go into a status of reasonable stability, followed which the third phase sets in, where you have predominantly the liver failure kind of symptoms. So the timing is also important. Based upon that, what phase the patient is, you have to go for the focused investigations, right? So assuming that this patient had come to us in a more hyperacute kind of scenario, what would have you done differently? So somebody is brought in with a history of say 30 minutes of ingestion.
First of all, we will wear a personal protection equipment. Then we take a proper history of what the patient was taken. Then we decontaminate the patient with irrigation of the and also remove the cloth for forensic medical legal purpose. Then in unknown poison, we will within 1 or 2 hours patients arriving, we will take riles tube for gastric lavage, and activated charcoal also we give for decrease the absorption, sting absorption. Then we send the routine blood investigation, and gastric lavage content is taken for medical legal purpose, and urine and blood also sent for the specimen to check out. And
Okay.
When all will you avoid putting rails tube and gastric decontamination?
If there is initially, if airway was not maintained, we will first maintain the airway, then we will put the rails tube. Otherwise, if there is delayed presentation more than 4 hours, there is no purpose to gastric. If there is low GCS, and also in caustic injection like alkali or like any detergent injection, there is no purpose of gastric lavage. And also acid injection or alkali injection. Then hydrocarbons injection, the contraindicated.
Then any heavy metal poisoning, any as you told hydrocarbons, then essential oil poisoning, these conditions and all we won't be doing. And if at all the antidote, if this gastric lavage is consuming our time to give the antidote, then that time also we must first give the antidote first. In such scenarios, it shouldn't be delayed. If we can do both hand in hand, it is better. But if it is causing unnecessary delay, then directly go for the antidote. Okay.
Then second is activated charcoal. Activated charcoal, we in adolescent dose is 50 gram to 100 gram, and the ideal dose is 50 gram. 50 gram we mix it into 50 ml of water, then they given by riles tube. It will delay the absorption.
So dose is 1 gram per kg.
1 gram per kg.
Children are all 1 gram per kg.
0.5 to 1 gram per kg.
Okay. So in this patient adjuncts to primary survey, so we took a VBG. Then what else will you take?
Also we look at the PT, INR, LFT to know the progression of any liver failure, RFT for any acute kidney injury progression, and blood routine, CBC.
What electrolytes?
Electrolytes.
So what all electrolyte abnormality will you expect?
Hypomagnesemia. In zinc phosphate there is hypomagnesemia. In white phosphorus or yellow phosphorus there is hypocalcemia, hypokalemia.
Okay. Then as the patient goes into liver failure, there can be hyponatremia, then recurrent hypoglycemias can be there, then lactate elevation will be there.
Gluconeogenesis, then recurrent hypoglycemia also will be there.
Okay. Suppose you are seeing hypophosphatemia, what does that mean?
kidney failure.
Okay, in renal failure, it will be hyperphosphatemia, hypophosphatemia. It is actually a good sign. Hypophosphatemia is usually seen because of the regeneration of the liver. So hypophosphatemia means it is a good sign, and the liver is regenerating. That is the indicator. Okay. So if it is going to severe hypophosphatemia, you can plan considering correcting that. Otherwise, it will improve by itself. We don't want to unnecessarily correct. Okay. Okay. Sample history.
Sample history. There is a 36-year-old male patient. He has an alleged history of rat poison on 23rd December. Then he presented to the general hospital with multiple episodes of vomiting and abdominal pain. The hospital advised for admission, but he absconded from the casualty on the same day after the gastric lavage. The next day on 24, he again presented with abdominal pain and vomiting. Then from outside hospital, due to the elevation of PT-INR and LFT, they give injection vitamin K and NAC infusion they started. And from outside hospital, they given 16 pint of FFPs. Then further elevation of PT-INR and LFT, they came to our hospital for further management.
Okay. So, from history, was there any detail about the quantity of compound he has taken?
I asked about there is referral letter. There is nothing mentioned. Patient saying some pinch of paste he was taken.
Pinch of paste. Okay. And then you want to make any comments on the things which is done there, like vitamin K and FFP and all? Is it recommended?
Basically, it will be affect our grading of the acute liver failure or King's College criteria. But if the patient is deteriorating or any bleeding manifestation is there, we can give FFP and vitamin K. After assessing how is the PT-INR, then we can get the idea about if the patient is required in liver transplant.
So the recommendation is very clear that during the acute phase, it is not very much advisable to correct the INR, okay, unless it is life-threatening or the management plan is already made. So these kind of patients should be ideally in a center with liver transplant backup. Okay, and then because once the score breaches the cutoff, because you'll be telling about the King's College criteria also, no? So once it breaches, then it's okay to correct. But otherwise, PT-INR is a key factor on which the decision is being made. So it is not at all advisable unless there is a pressing indication, like life-threatening situation, as you told. Just wait. Don't give vitamin K. Don't give FFP. Okay, because that again is going to mess it up, the whole workup. Okay, fine.
So what was this patient's INR value in outside hospital?
Outside hospital, while you reaching on 24th, the PT the PT INR was 1.14. 26 it becomes 3.62. Then they transfuse the FFP, and 27th it becomes 5.13. Okay. While reaching in our hospital, that is 10.38 PT INR.
Okay.
And OTPT.
When did the patient meet the criteria, King's College criteria? When do you think, at what INR value the patient meets the King's College criteria?
The INR value individually take it is more than 6.5, or we can three of the following variables. One is age. Age is less than 10 or more than 40 years, and cause is non-A, non-B hepatitis, and INR is more than 3.5, or serum bilirubin is more than 17.5. In this condition, any 3 is acceptable, then INR is more than 3.5. Otherwise, individually, INR is more than 6.5. It is transplantation.
So even though the patient was corrected with FFP and vitamin K from outside hospital, by the time patient reached here, patient has met criteria.
Yes.
Okay. So suppose this patient has met the criteria and we are planning for a transplant. As a bridging therapy, what all will you do?
Bridging therapy, we can do plasmapheresis and cytosol.
No, initial stabilization in the ER.
In the ER, gastric lavage.
No, now it is 4 days now.
We can start a Bronac infusion. We can start with N-acetylcysteine. We can give 21 hours regimen, a loading dose of 150 milligram per kg. Mixed with 250 ml of D5 water for 1 hour.
That is for paracetamol poisoning.
Otherwise, we can 300 mg or 600 mg per kg infusion per hour infusion we can start.
Okay.
Other than that, we can fluids.
Okay, we'll discuss after some time. So, what was the examination findings? This patient.
On head to examination, there is some hesitation cuts over the left forearm. Otherwise, the patient has no other comorbidities. Patient was not taking any medications also. System-wise, there is upper abdominally epigastric tenderness is there and left epigastric tenderness, right hypogastric tenderness is there. Otherwise, all system is in normal limits.
Okay. So, what was done for this patient?
Now we are planning for liver transplantation. Because now the OTPT, initially the OTPT is at 24 it is 34 by 30 OTPT. Then at 27 it was elevating like 1500 and then now it was decreasing trend. So if it is decreasing, it becomes necrosis. Also there's a reason for decreasing the OTPT. So liver transplantation is their planning.
Okay.
Sort of planning for them.
So, till they get a donor and rest of the things for workup, liver transplant workup is going on, how will you manage this patient in ICU?
Now we get an idea about the King's Collagen. You can give FFP and injection vitamin K.
So, in this patient, you can give vitamin K, FFP. For more than FFP, what will be the ideal choice? Cryo or something?
Platelet concentration.
You can use 4-factor PCC. What is that? Prothrombin complex concentrate. So, what are the 4 factors in 4-factor PCC?
2, 7, 9, 10.
So 2, 7, 9, 10 is there, and sometimes 4-factor PCC at such we won't be getting. Sometimes in that 4-factor, factor 7 gets used up or gets destroyed early. So it can become 3-factor PCC also. There will be 2, 9 and 10 only will be there. So that can be given for correction, and vitamin K can be given. So what all cutoffs will you in this case? So till what all cutoff will you give injection vitamin K, oral vitamin K, rest of things? So initially, just imagine this patient presented you with an INR of 3. What will you do?
If King's College meter, you can give.
Not yet met.
Then there is no any bleeding manifestation. We can.
We will wait. We will monitor the INR. Okay. Then.
And if you met the criteria,
suppose the patient has met the criteria.
You can give injection vitamin K 10 mg.
If it is more, if the INR is more than 4.5, we can consider giving oral vitamin K tablets also. 2.5 to 5 mg oral tablets can be given if there is no bleeding manifestations and all. And if the INR is going more than 10, then we will be considering giving IV. So if it is less than 4.5, we will observe. More than 4.5, we can give, if the patient has already met the criteria, we can give vitamin K tablets, and more than 10, we can give the 4-factor PCC vitamin K injections. Okay. So
yeah, other than PTINR, is there any other test which can guide the transfusions?
APTT.
What is thromboelastogram? So an alternative test will be thromboelastogram, which kind of looks more comprehensively at the whole coagulation process. What you need to give, is it FFP, is it tranexamic acid, is it any other cryoprecipitate, things like that. We will be able to have a comprehensive idea. Okay.
Then what else will you do? We are waiting for the liver transplant. What all will you monitor? When all will you understand that the patient is worsening?
Patient went into hepatic encephalopathy and PTINRs are elevating. Then OTPT becomes.
So in rat poisoning itself, different contents are there. Ratol is mostly zinc phosphate. Then what are the other poisons in rat poison?
White phosphorus, yellow phosphorus, and super Warfarins.
Super warfarins are there. So this might contain both. So what is the why it is called a super warfarin?
Super warfarin because it is a more potent action than normal warfarin. So it is prolonged action and more
Prolonged
potent.
action. Ideally, it will be somewhat the same action. The action starts only after, like warfarin, only after 3 to 4 days. But it is actually inhibiting the vitamin K epoxide reductase. So vitamin K regeneration will be inhibited by that, and it will be having a prolonged action than
More
warfarin.
than
Like
7 days action.
will be there.
The
Okay.
patient will deteriorate after 48. Means initially patient was become normal, and patient will start to deteriorate after 48 to 72 hours.
Okay. So, so this patient already coagulopathy has set in. Then we are checking for the encephalopathy, whether the patient has gone in for encephalopathy. Okay. So how will you treat that if suppose the patient goes into altered sensorium?
Encephalopathy, we can start with gut sterilization with rifaximin, loose enema.
Gut sterilization by rifaximin and gut clearance by
Loose
enema. Then
syrup loose enema. Then antibiotic also we can.
for cerebral edema,
Cerebral edema 3% NS. 20%
what is the target sodium you will set?
more than 155, 156.
More than 145 to between 145 to 150 we need to set in. Then for anti-edema measures.
Injection mannitol also you can give, and injection Levipil if the patient went into any seizure episode.
Okay. Then what are the other abnormalities? So coagulopathy we have discussed, hepatic encephalopathy we have discussed. Then what all abnormalities will come? Electrolyte abnormalities might come. As
abnormality, if hypomagnesemia we can correct it with magnesium sulfate 1 gram IV followed by every 3 to 4 hours we can give 1 gram magnesium. Then hypokalemia we can give by injection KCl. Hypocalcemia also we can correct by calcium gluconate.
Then what else can happen when liver is failing?
For the patient went into low GCS, in this patient we will intubated the patient because patient poor sense. Initially patient was in altered sensorium, then patient become agitated, then patient GCS becomes poor, then we intubate to maintain the airway, intubate the patient. That also will happen. Other than that,
and patient GCS
we can do the continuous renal replacement therapy also done for this patient.
There is always chance for recurrent hypoglycemia. So that also, if the patient's GCS is dropping, first check for that. Okay.
Hemodialysis also.
Okay. Anything else? Okay. So we need to watch for the till the patient goes to liver transplant, we need to watch for the coagulopathies, hepatic encephalopathy, the electrolyte abnormality. There is chance for liver failure induced hyponatremia, but we need to target higher targets of sodium for managing the encephalopathy. Correct all the other electrolyte abnormalities and all. Okay. As a part of bridging, we might have to intubate the patient. Dialysis support might be required, and plasmapheresis and cytosol therapy if at all there is a delay in liver transplant. Okay, so this patient is now waiting for transplant, right? Okay, anything else? Okay, thank you.